Hello and welcome to this author interview. Sorry for being a few minutes late, but we had some technical problems. This is Howard Bachner, Editor-in-Chief of JAMA. This is Conversations with Dr. Bachner, and I'm joined today by Gregory Poland. Hi, Greg.
Hey, Howard. Good to be here.
So for our listeners who don't know who Greg is, he's one of the world's experts in vaccines. He's at the Mayo Clinic, and he's the Mary Lowell Leary Professor in Medicine. And Greg's been at this for well over 3 decades. But before we start the conversation, I just wanted our listeners and our watchers to understand what we're trying to accomplish with JAMA through the COVID-19 pandemic. The first is our research papers, which is the basis of the journal. But around that, we build numerous opinion pieces, viewpoints, editorials, and then, of course, our clinical review and education section. But more importantly, over the last couple of weeks, we've tried to bring these live streams to people, as well as podcasts. And that's a mix of live streams and podcasts. I think people are aware that I've done quite a few with Tony Fauci and some other people, and Greg's agreed to join us today. So thanks, Greg.
You bet. This is important that we get information out to people who need it most.
So I wanted to focus on 2 issues. This is a bit more looking around the corner of what's coming as we move through the acute phases of the pandemic, which I have tremendous faith about the capacity of the U.S. healthcare system and our committed physicians and workforce to respond. But I want to look a bit into the future. But Greg, every time I have done these in the past, one question that keeps coming up with people from folks who are listening is, why will it take so long to develop a vaccine? Are there any shortcuts? Is there anything new that would potentially bring us a vaccine on this side of January?
Yeah. It's hard for me to see that we'd have it on this side of January. And I should sort of frame this, Howard, by saying that the process is in many ways designed to be slow, reflective, peer-reviewed, evidence-based, because almost as opposed to any other therapy that we do, we're taking healthy people, giving them a vaccine to prevent an infection they might encounter and might have symptoms from. So what takes so long is not so much the science part of building the vaccine, it's the safety testing in enough people across enough time.
So your sense, like Dr. Fauci's and other people, it's a year away.
Oh, easily. I mean, if you take as another example, a major public health emergency, Ebola vaccine, that took 6 years to get to licensure. Now, that epidemic also kind of stopped and started, whereas I suspect our attention will be a little more sustained here. But a couple of things are happening that I think get to the root of, can you move things along? I know my institution and other institutions are doing everything they can for expedited IRB review so that we can get approval to do these studies as quickly as possible. I know at the FDA, they're yanking reviewers right and left so that applications can be reviewed quickly. Almost unprecedented is that the FDA is allowing non-human primate studies and human studies to happen simultaneously. It has always been the case that it was small animal, non-human primate, pause, then allow first-in-man trials. And they're moving toward letting those latter 2 things happen together. But nonetheless, just the effort involved in enrolling thousands to tens of thousands of people into a trial and looking for safety as well as efficacy is a tough row.
Yeah, and I do want to remind our listeners before we move off this topic is once we develop the vaccine, that's no guarantee of efficacy.
Correct.
So, Greg, there's about 50,000 people in the U.S. who've now been infected with COVID-19. Yeah. Do we know much about their immunologic response, and what form does it take, and will it be sustained?
Yeah, those are really critical questions, and I like to answer it this way. While it is a beta human coronavirus, and we have known about those since the 1960s, with this specific strain of coronavirus, Nobody's knowledge is greater than 12 weeks old. That's it. So we don't have a lot of pixels on the canvas yet to really see the picture clearly. We know, for example, that with SARS, that immunity waned very quickly in those individuals. With MERS, it did not. Why the difference? It's not really clear. With the 4 seasonal beta human coronaviruses that circulate, cause all the upper respiratory infections that you've seen in your practice, those people lose immunity in months to a year or two. Why is that? Well, it's because it's primarily a Th2 focused immune response and not so much a cellular driven immune response where memory is included. Now that impacts our knowledge not only on are these folks going to be protected, but also when you have had these many infections, have you started to develop any herd immunity for the years following? And it informs vaccine development.
Now, is science advanced enough? I mean, people are now clearly being infected. They're surviving, thankfully. And so we will be able to access some of their immune system after they have survived. Has science advanced enough so that we'll know what their immunologic response looks like, or is it going to take more months to understand that?
It'll still take more weeks at least to understand that, because what you really end up doing, or what my lab and a number of other labs do, called systems biology type studies. So we really want to know, are T follicular helper cells involved? Do we see involvement of memory plasma cells? Things that would help us to better understand, are we likely to see long-lasting immunity, or is this going to be short-term humoral immunity?
Now, as I said, no one knows the time period, but say 2 months in the future, it's quiet in the U.S. around new infections, similar to what's happened in China, Korea. And we get to the fall, and we don't really quite know what's going to happen. Will it be safe to bring people back to college campuses or to have large meetings again?
Yeah. These are the kinds of questions that make me sympathetic to the weatherman.
Okay.
They're very hard to predict, but there's a key concept, 2 key concepts really, one that will be familiar to our listeners. What we have seen in the last 11 weeks is the very tip of the pyramid. We don't know that great base of the pyramid yet, and we will once testing gets accelerated, and that is happening. The second is a lag period in the dynamics and kinetics of an infection like this. And what I mean is what we're seeing now in terms of cases, which I don't believe have come anywhere near peaking yet. So that's an important point. What we see right now is a reflection of transmission 2+, even out to 4 weeks ago. So what has to happen when we talk about flattening or bending the curve is that you've got to get down to a small enough number of cases and wait 2 or 4 more weeks before you really sound the all clear. And I think that's going to be a very tough decision in the fall time, as you say, with all the college kids and the resumption of kind of normal business. How do we make that decision? And I think we're literally kind of building the airplane while we fly it here. And we're going to have to watch and, yes, pay attention to what some of the modelers are saying, but equally as important, what are we actually seeing? And then add 2 weeks to that.
Can you see a future that would involve forms of passive immunization or convalescent serum? I mean, convalescent serum is a century old. Not a lot of good clinical trials, but on the other hand, it's been used in almost every other pandemic. And I'm just wondering, as you peer into the future, into August or September or October, and we're trying to get large groups of people back, or you're bringing students to a college campus, can you see convalescent serum or passive immunization being part of that process?
Yeah, so probably not.
Okay.
I don't think that we would have enough, but I do think that what we need to do right now is we need polyclonal, even monoclonal antibody development. We need that now. Simultaneously, you see antivirals trying to be repurposed or redirected and studied for this. And then of necessity, lagging behind that will be vaccine development. The issues with, for example, plasma-derived therapy, polyclonal antibody, immune globulin, is that maybe you get a dose or two out of each person you plasmapherese. So the idea of getting a very large number, when you and I were college students, if you went overseas, you got immune globulin to protect yourself against hepatitis A, right? There was plenty of it. I don't think we're going to have quite that kind of supply. Now, monoclonal antibodies would be a possibility because you can synthesize those in mass quantities, but they've got to go through, the usual clinical trial kind of time frame. The thing that's really going to protect us over the mid to long term is getting a vaccine. And I have some reservations about some of the approaches being taken.
Now, this is an RNA virus. It's not something I know that much about. Does that affect vaccine development?
It does in a way. I mean, you're right. This is a positive sense, single-stranded RNA virus. In this case, I think it actually makes vaccine development a little easier. We know the structural and non-structural proteins. We have some indicators of immunity developing from the S protein or the so-called spike protein. My concerns about current vaccine development is that they're focused almost entirely on S protein, which is a very Th2-directed immune driver as opposed to including Th1. And the functional consequence of that can be what was seen in spike protein SARS vaccine trials in animals, where you actually got disease enhancement in some cases, and Th2 pulmonary pathology and hepatitis-like pictures. The other thing is that provides a mutational force on that S protein. So what we would generally like to do is to say, well, let's include the S protein, the N protein, maybe the E or M protein, so that a virus can't mutate around the vaccine design. And as you and I were talking about earlier, hopefully the development of more broadly neutralizing antibodies would be a better immune picture, if you will, trying to prevent not only mutation around it, but also antibody enhanced disease, which we've seen with lots of vaccine candidates.
You've been at this a long time. You have an enormous amount of experience. China's reporting essentially no cases. I don't know how active their detection is at the moment, but clearly there's less cases, and that's been true in almost every other country. I mean, Taiwan, Singapore, to me, are more difficult because they're so small. They never had many cases, but Korea had quite a few cases, and they're really much less now. Are your instincts suggest that it's like influenza and that we will see more in the fall, or it's not like influenza? Sometimes we want it to be like influenza, which usually wanes in the spring and summer, and then I go, people are hopeful it's like influenza, but there's a problem if it's like influenza. Do you have any instincts about that, Greg?
Not really. We sort of have 3 points on a curve we can't quite see yet. Point one was that the seasonal beta human coronaviruses do recur every fall. Point two, the SARS virus, or SARS-CoV-1, as it's actually known as now, started in November of 2002, disappeared by July of 2003. Now, a fundamental difference is there really was not asymptomatic transmission the way there has been with SARS-CoV-2. Third point on the curve is MERS, which has still circulating in very low levels on the Arabian Peninsula, but still small clusters of cases here and there. So which one will this be like? Wow. We're hoping because of genetic similarity to SARS that it will be more like that. And as we get to warmer weather, we'll see a dampening of cases. Now, that's not a good sign for the southern hemisphere. sort of like what you're suggesting? And then would it recirculate for those of us that didn't get infected the following fall? And we're just going to have to stay tuned. But it makes a critical point you mentioned, which is the need for ongoing surveillance. We're going to have to be very careful about that.
Well, it was interesting because about a week or 10 days ago, I'm sure you read about it, the UK was debating whether or not they could somehow create herd immunity by keeping their pubs open and letting quite a few people get infected. That was suggested. It didn't, I think, go over very well with some of the leading health scientists, and it's very interesting because they really dramatically changed just in the last 2 or 3 days to really accept the guidance that WHO has offered about social distancing. It was really quite a reversal. So I don't think they're pursuing this kind of herd immunity approach.
Thankfully.
Greg, have you seen enough data? It comes up every time I do these live streams, and Michael's sending me questions. People really want to know if individuals can get reinfected. Do you have a sense of that yet, or there's not enough data, or it's really not likely? Can you answer that question?
Yeah, not enough data. Again, with the seasonal coronaviruses, absolutely they can. So that suggests that there is a mechanism. With SARS, that didn't happen. With MERS, it hasn't happened that we know of. So I suspect what happens is that the S protein is so elegantly and efficiently adapted, particularly in this case, to the ACE2 receptor, that you're not getting low-level infection. You're getting pretty hefty infection, and I think that drives a more balanced immune response that I'm hoping is more likely to lead to longer-lasting, durable immunity. But this is a problem. We are beginning to notice this with some of the standard childhood vaccines that we give, where we know, for example, with closer study that when you're not having concomitant circulating subclinical challenges, that mumps vaccine antibody-induced durability wanes really pretty quickly. Same with pertussis. So will this be, measles-like immunity or mumps-like immunity? Don't know yet.
Well, one of the questions that came in is, particularly in the child population, and our viewers and listeners know I am a pediatrician by training. Yeah. I am quite sure what will come up quickly is should children still receive their immunizations? Can you comment on that? I haven't seen an opinion from the American Academy of Pediatrics, but generally they've been very strongly committed to immunizations.
Yeah, you're exactly right, Howard, and they still are. AAP did release a statement.
They did.
That basically said this, immunizations are important to get, but the one caution is what we don't want is 100 kids, and maybe I'm exaggerating here, but 100, 150 kids in the waiting room, all mixing, waiting to get their immunization. So let's do this by appointment. Let's do this carefully so we don't actually induce risk. Now, the other big point about this, and I think a lot of clinicians forget about it, especially with sort of the drive-through testing, they're thinking binary, COVID yes, COVID no. But depending on where you are in the United States, you've got influenza A, influenza B, parainfluenza, human metapneumovirus, RSV, all kinds of viruses, mumps, measles, pertussis. You've got all kinds of viruses and bacteria, respiratory pathogens circulating. And so what you don't know in a given case, if you don't do a respiratory pathogen panel, is, and the one that would be the most likely statistically, is co-infection with influenza and SARS-CoV-2. Well, one we have a definitive treatment for, and the other we don't. So you'd want to know that and reduce the burden of disease, particularly from a pulmonary point of view.
Well, in months to come, years to come, we'll rehash the testing fiasco in the United States. I spoke to Michelle Gong from Montefiore earlier.
Oh, yeah. I saw that.
Yeah, Michelle said, as soon as we got testing, it totally changed everything. They could organizationally and logistically sort out what to do in their institution. They brought it in-house. It's a few hours versus sending it out for a few days. I mean, you can quarantine someone at home and say, you know, in a few days we'll know if you're a disease. But if you're trying to run a hospital, a healthcare system, a few days doesn't really help you.
It's critical.
Yeah. So I'm sure we'll come back to that. Now, an astute listener said, "Well, Howard, you asked Greg about children, but children are pretty protected in the sense that they have not gotten much disease, or if they've gotten disease, they've fared pretty well." Yeah. What about adults and immunizations? Would you change the recommendations for adults over the next 3, 4, 5, 6 months?
Yeah. So, no clear guidance one way or another has come out. We know that vaccine preventable diseases in adults are the majority of cases. When you look at deaths due to vaccine preventable diseases, over 90% of those are in adults, of course, not kids. Right. And so they are important. In the midst of a pandemic in a city, let's say like New York, I would probably say I don't want a lot of patients in my waiting room. I want you to get flu vaccine because that's circulating right now. Those symptoms overlap so carefully that I want to be able to take a bunch of that off the system. I probably want you to get your pneumococcal vaccines. But the rest of the vaccines, I'm perfectly willing to say, you know what, there's a little more risk by you traveling to my office, to waiting in my waiting room. Let's delay those for a few weeks. I don't think that's likely to do any harm. I feel a little differently with the respiratory-borne pathogens for the reason I mentioned, and that's co-infection.
So a crystal ball, it's, when we chatted by email, you said, Howard, there's so much unknown.
Yeah.
But do you have a sense of what the next month, 2 months, 3 months are going to look like, Greg?
Yeah. I think we have not come anywhere near the peak of this yet. I think what we're going to see is what has historically been seen in every pandemic where we have data, and that is people start to flee cities, particularly where there's going to be any kind of containment or cordon sanitaire type restrictions. That just broadens out. One person has called these rings of fire that'll spread out and eventually coalesce. I think we're going to see a lot more infections. I think the healthcare system is going to be under increasing stress. I think we're in this for months, plural, not weeks. I don't think this is going to be 2 or 3 weeks and then, the all clear flag goes up. I don't see it happening that way.
I've been impressed when I've spoken to people around the country. Obviously, it's a tremendous struggle in New York City, and to our listeners who are there or have friends there, I wish everyone to be well, but particularly the healthcare workers. As I've said, you can double the number of ICU beds, but if you either don't have equipment or healthcare workers, it will make no difference. Mm-hmm. But we seem to have bought some time from China, which we didn't do very well, was squandered around testing. But we bought some more time in different areas around the country. And in talking to people, I really do think health systems have really re-engineered themselves incredibly quickly, just within the last 10 days to 2 weeks. Telehealth, telemedicine. I think the ICUs are really ready to expand if they have sufficient supplies and healthcare workers. Hopefully, testing in hospital testing, rapid exchanges will be available everywhere in the country. So I feel like we've bought another week or two, at least outside of New York, and I hope we really use that time wisely. I don't know what your impressions is of that scenario.
Yeah. As I talk to my colleagues around the nation, I feel very similar, Howard, to how you feel. Is that there's a few, if we will call them epicenters, right, where the system has been very strained. But you know what? I think after SARS, after MERS, after pandemic influenza, a couple of aborted potential pandemic influenzas, I think the healthcare system got the message. There was concern, remember, about bioterrorism after 9/11. And I think preparedness is at an all-time high. I think people are more prepared for this. Mayo Clinic, for example, we've got a bright young guy who actually trained in this kind of preparedness. And that's been a big boon to our very large system being prepared. And yet, when something really wallops you, like New York City, you're hearing things like they've got 7,000 ventilators and they need 30,000 more. I think the other thing that has helped is that the Strategic National Stockpiling Initiative has been of benefit. Now, they need to really open those gates up. They can replace them at another time, but they need to get those mass PPE out to our fellow healthcare workers. So I personally think that in probably every arena other than testing and other than vaccine development, we have been as prepared as I think you can ever be for this. And I'm only putting the finger on vaccine development because, SARS, MERS, and now SARS-CoV-2, 3 times in 18 years. We could have, should have had a vaccine, but they occur just beyond the human attention span. And once it kind of dampens down or disappears, we turn the research spigot off, and that's not a good way to do science. It's an ongoing endeavor.
Yeah, one of the really nice things to see over the last few years is the dramatic increase in the NIH budget.
Yes,
it's gone from 30 billion to 43 or 44 billion. Some of it's been earmarked for the brain initiative. Some for cancer, obviously the HEAL initiative around the opioid epidemic, but it's been a dramatic increase, and I'm pleased to see that Congress has been able to invest once again. The U.S. has been kind of the leader in biotechnology and science, and I want to make sure that we have the capacity to retain that leadership position around the world.
Absolutely, and that's a not only does that help people around the world, but it's a national security issue. I see, by the way, looking way out, one silver lining that I haven't heard many people talk about. I think for this younger generation, this will be as defining as the space race was in mine. And I think and I hope that we're going to attract a lot of bright young women and men into the science fields where they may not have had any particular motivation to do so. So all in all, I think the way you opened is exactly right. We're going to get through this. We're going to learn some lessons, and we'll be even more prepared for coronavirus 4.
Yeah, my Lord, I do remember Walter Cronkite. He loved the space initiative.
Yes.
Walter Cronkite loved the space initiative.
Yes.
So this is Howard Bachner, editor-in-chief of JAMA. This has been Conversations with Dr. Bachner. I'm reminded by Mike Berkowitz to say that the next live stream will be Friday at 11 a.m. with Doug White, an intensivist and ethicist from Pittsburgh. And we're going to talk about a very difficult and emotionally painful issue, and that will be the potential for rationing in the U.S. healthcare system, which is something I don't think any of us have ever purposefully seen. So that will be 11 a.m. on Friday. Greg, I can't thank you enough for joining me. Be healthy, be well.
Thank you, Howard. As a journal editor myself, I admire what you're doing and the way JAMA has really been a resource center for all of us. So thank you.
All right. See you, Greg. Bye-bye.
All right. Bye-bye.